Good evening. We're in for a special treat tonight. I'm very privileged to be the moderator for this panel that we have. My name is Dr. Fred Dennis. I'm a McGill-trained emergency physician who practiced for 30 years in Los Angeles, including 10 years at Cedars. But after getting an MBA, I transitioned to administration. I'm currently medical director of Torrance Memorial IPA, and I've had a chance to see the practice patterns and the expertise of our panel in that particular role. And I think you're going to be delighted. These are all top experts in their field and very highly respected. Before I introduce them, I just wanted to say there's been one change in the program, which was Dr. Tim Lesser, who was going to talk on prostate cancer, had an emergency come up and he is unavailable, unfortunately, but I think we'll have plenty of opportunities here to make sure all of our questions get answered. The panel consists of the three people who are, I don't know if the camera is on them. Dr. David Chan, who is an oncologist at Cancer Care Associates, and he's going to be speaking on breast cancer. We have Dr. Clark Fuller, who is a cardiothoracic surgeon on staff at Cedars and surgical director at Hunt Cancer Institute, and he'll be talking on lung cancer. And finally, we have Dr. Megan Linnebur, who is a colorectal surgeon and on faculty at UCLA and here works at the Association of South Bay Surgeons. She'll be discussing colon cancer. So I'd like to introduce our first speaker, Dr. David Chan. He's the breast program director for Torrance Memorial. He did his initial training in internal medicine at UCLA and then oncology at Stanford, both top-notch. While teaching at the Revlon UCLA Breast Center, he wrote the book, Breast Cancer, Real Questions, Real Answers. And he was just sharing with me, he is been here a long time and has seen a lot. And it's so great to have an expert like him to be talking about this extremely important topic. Dave?
Thank you, Dr. Dennis. So what I'm going to talk to you today about is some facts about breast cancer risk and then discuss screening. So there's a common misconception among the lay public that breast cancer is a disease of hereditary. And if you don't have another family member with breast cancer, you don't really have to worry about it. And that's why nationally we see that there's only about half of women that are eligible to have mammograms actually go ahead and get them. And the first slide shows that the inherited breast cancer risk really is only about 5%. These are the patients that have BRCA mutations or RAD51 mutations, ATM mutations. These are mutations that are not tested on direct-to-consumer tests like 23andMe, but by gene sequencing. And there are actually about 8 genes that are associated with a higher breast cancer risk, but only 5% of breast cancers have those genes. 80% of newly diagnosed breast cancer patients in North America today don't have another direct relative with breast cancer. Only about 15% have a mother, a sister, or a daughter with breast cancer. So breast cancer really is a disease of lifestyle and so it's related to socioeconomic factors that I'm going to review. So this is a slide from about 10 years ago, 15 years ago from the American Cancer Society. It shows that the United States and North America has a breast cancer risk 8 times higher than that of the most underdeveloped country. With industrialization, countries like Japan and China are getting caught up, but still in rural China, breast cancer is very rare. And the main factors that contribute to that is an industrialized lifestyle. So breast cancer is very much associated with obesity and inactivity. And in fact, just recently, obesity has now surpassed tobacco as the major leading cause of cancer in the United States. And it's responsible for 50% of breast cancers, colorectal cancers, prostate cancers, and pancreatic cancer. Developed countries also have delayed childbirth, lower rates of breastfeeding, and I'll review that in a different slide. Breast cancer is also a disease that increases with age. So every decade, starting 30 to 40, 40 to 50, 50 to 60, the risk of breast cancer increases. So these risk factors from industrialization are factors that take decades to manifest. It's like smoking and lung cancer. Somebody starts smoking, they don't get lung cancer like a month later. They get lung cancer decades later. And just as in smoking, stopping smoking doesn't really reduce lung cancer risk for at least a decade. So if we're going to change lifestyle, we should start sooner rather than later. Other risk factors include alcohol, cigarettes, and estrogen replacement therapy, but those are really small risk factors. They don't make up the bulk of causes of breast cancer. A lot of my patients come in, they're postmenopausal and they've been on estrogen replacement therapy for 5 or 10 years and they have breast cancer. They think that that was what caused it. I'm going to show you in a couple of slides down the road that breast cancer takes a long time to develop, and estrogen replacement therapy is not a risk factor that's really meaningful. There was a very important study about a decade ago called Women's Health Initiative, and they looked at the risk of breast cancer from taking estrogen replacement therapy, and it was 0.1% per year. So in other words, if you took estrogen for 10 years, your risk really increased by 1%. And in fact, that risk was primarily associated with the progesterone that was given. In patients that took estrogen alone that had had hysterectomies, they actually had no increased risk of breast cancer. We talked about hereditary breast cancer risk making up a small percentage of breast cancers as well. So one of the things that we're dealing with over the past several decades is this obesity epidemic in the United States. And only about a third of us as adults are at optimal weight. 2/3 of us as adults are either morbidly obese, or overweight. And the definition of obesity kind of varies between a BMI of 35 or 37, depending upon what you look at. But how obesity causes higher cancer risk is that it's associated with something called insulin resistance. And insulin resistance refers to needing higher doses of insulin to maintain good blood sugar control. And insulin is a growth factor promoter. When we're growing cancer in the test tube, we're going to put insulin into the culture and the cancer is going to grow faster. So more insulin results in more cell proliferation and more mutation. The other factor that's associated with high socioeconomic status in industrialized countries is early menstruation, late childbirth, and very short breastfeeding. In fact, if you look at counties in the United States, the most wealthy counties have the highest breast cancer risk. The example is Marin County, which has a very high breast cancer risk. And that's related to having adequate diet, very early menstruation, and then our daughters going to college and then starting careers, and they're starting their child birth years in their late 20s and often mid 30s. In developing countries, menstruation occurs later because of inadequate calories. And very often by the time a woman is 20, she's had 2 kids and she's breastfed each for about 2 years. And what that does is that stops the estrogen stimulation of undeveloped breast tissue. And after lactation, after breastfeeding is stopped, the breast cells in the ducts typically go through a period of hibernation. So about half of all breast cancers in the US are related to being overweight, and about 30% or almost a third are related to the timing and delayed childbirth and lower breastfeeding duration. Exercise also lowers cancer risk in general and breast cancer in particular. And when we exercise, what we do is we lower levels of inflammation that occur from being sedentary. And these low levels of chronic inflammation impair our immune function. It impairs T cell surveillance. And it also leads to more obesity and also more insulin resistance. Starting at the age of 30, if we don't do anything to maintain our muscle mass, we're going to lose 1% of our muscle per year. So between the ages of 30 to 60, if our weight stayed the same, our body changes and a third of our muscle is replaced by adipose tissue. Again, more inflammation, more insulin resistance. So it's very important to understand that both optimal weight management combined with exercise is important in terms of lowering breast cancer risk. This is a schematic diagram of how breast cancer develops, and this is a process that takes decades. We have breast ducts that are lined with normal cells, and then with the things that we do to increase cell proliferation and mutation, we start seeing that the number of those cells within the ducts increases. That's called ductal hyperplasia. And then over time, those cells start becoming slightly abnormal. That's called atypical ductal hyperplasia, or ADH. And then with further progression, we see cancer cells within the ducts, but not invading the ducts. That's called ductal carcinoma in situ, or DCIS, stage 0. Eventually, when the cells have enough mutations that they break through the wall of the ducts and spread through the fatty part of the breast, that's called invasive ductal carcinoma, which is breast cancer. 90% of breast cancers occur in the ducts, the tubes of the breast that carry breast milk. About 5% occur in the lobules, the part of the breast where breast milk is made during lactation. So this slide is really important, and you're going to have to understand that we don't diagnose breast cancer by mammogram or ultrasound or MRI. Those tests tell us when we need to have a biopsy done. Breast cancer is diagnosed by biopsy. And this is a biopsy of DCIS. The purple cells are breast cancer cells confined to the ducts. The pink walls are the ducts of the breast. And that transition from DCIS to breast cancer takes years. Sometimes that doesn't happen at all. In high-grade breast cancer, that can happen a third of the time over a 10-year period of time if that's not removed. And this is an invasive breast cancer. The breast cells have gone through the ducts and into the fatty part of the breast. So this schematic diagram shows the first breast cancer cell, and then progression over time to a breast cancer that's 1 centimeter in size. 1 centimeter is 1 billion cancer cells. And this is for the typical breast cancer, which is estrogen receptor positive. That's the type of breast cancer that makes up about 70% of breast cancers. And the time from that first cell to 1 centimeter averages 8 years. The doubling time is about 100 days. So breast cancer is not leukemia. It's not a fast-growing disease. And this is very important later when we get into how frequently mammograms should be done in terms of illustrating that the more chances you have to find it early and small, the better the outcomes in terms of less surgery, less chemotherapy to get the same cure rate. Not all breast cancers are estrogen receptor positive. 15% are what we call triple negative. That means estrogen receptor negative, progesterone receptor negative, and HER2 negative. And 15% are HER2 positive. Those are faster growing breast cancers. And instead of having that 8-year window, they might have a 3 or 4 year window. So hold that thought when we talk about the timing of mammograms, and the frequency of mammograms. So this is a schematic diagram of the breast. On the left are the ribs, on the right is the nipple. And the tubes that go to the nipple carrying breast milk during breastfeeding are called ducts. As I said, 90% of breast cancers occur in the ducts, 10% occur in the lobules of the breast where breast milk is made. The breast lobules are scattered through the breast. They're not in really clumps like this diagram shows. And because they're scattered, when lobular cancers grow, they don't typically grow as a mass. They grow more in a Swiss cheese pattern. They're harder to see by mammogram. So about 30% of lobular cancers are not going to show up well on a mammogram. About 10% of ductal cancers don't show up well. Mammogram doesn't really see cancer per se. It sees the breast reaction to having the cancer there through immune response or inflammation where some scarring occurs or laying down of calcium deposits in a suspicious pattern. So you're familiar with mammograms. It's currently the best screening test for breast cancer. And mammograms really have a high yield rate when it's done properly. And it's really important to have mammograms done at a certified breast center. Torrance Memorial has a breast center that's just been recertified by the NAPBC. This is a very select certification. The staff work very hard to receive this certification, and it's the only one in the South Bay. And what that means is that the breast center has special qualifications in terms of the rigorousness in which mammograms are done, how they're read, how they're reported, and it's a reflection of the breast program in general. So all of us are very proud of our breast center, and we feel that patients have excellent care there. So when we do the mammogram, screening mammogram is a 2-view mammogram. A screening mammogram implies that the patient is asymptomatic. If a patient has a breast lump or they have a breast mass, they need to have a diagnostic mammogram, which is a 4-view mammogram with magnification views. But when we see something on a screening mammogram, we often will do an ultrasound to confirm. And this is an ultrasound transducer that's hooked up to a computer generating image. And you can see that that breast mass is seen on the ultrasound. It's the dark circle that's in the breast tissue. And if we see the abnormality on ultrasound frequently, we'll do the biopsy under ultrasound. We can also do MRIs of the breast, and an MRI gives us a 3D image of the breast. It's a computer-generated imaging using magnetic resonance imaging, and it requires a woman to lie on her stomach and go through an imaging tunnel over about 20 minutes. We do a scan without contrast and a scan with contrast. You can see on the left, there's a vague mass in the breast, and then with the contrast, it becomes obvious, and this is a breast cancer. The issue with MRIs is that they're very hard to do. They're hard to read. They're time consuming. And it's not a good screening test because it has too high of a sensitivity rate and too low of a specificity rate. In other words, it sees a lot of things that are not cancer. So we usually are not doing MRI screening except in special situations for patients that have genetic mutations. So how often and when do we start mammograms? There's an entity called the USPSTF. It stands for the U.S. Preventative Services Task Force. And they kind of upended mammogram screening in the United States in 2009 when they came up with their recommendation to hold the mammograms until age 50 and do them every other year. And that's exactly what has been done in the UK and Canada even before this. And the reasoning was that they didn't feel that doing mammograms earlier or yearly actually saved lives. And there was a huge uproar over this when the recommendations came out. It was done as a statistical analysis by a team of statisticians On that panel were no breast cancer experts, no breast surgeons, no mammographers. It was simply a statistical analysis looking at all the studies, good studies and bad studies. And some of those studies were done with 1970s era technology in terms of mammograms, untrained radiologists, and untrained radiology technicians. So the American Cancer Society, as a result of that, recommended that mammograms still be done yearly, but they be pushed back to age of 45 to start. And the American College of Radiology and the Society of Breast Imaging still stuck to their recommendations, yearly mammograms, starting at the age of 40. We had our NAPBC survey about a month ago, and I spoke with the surveyor, who was a breast surgeon from New York Hospital, and I asked her how many of the NASABP centers adhere to the guidelines from the U.S. Preventative Services Task Force, and she said none. She said all the centers are imaging once a year starting at the age of 40. The modern mammogram studies show that with modern technology, trained mammographers, trained mammotechs, that mammograms reduce breast cancer death by 40 to 50%. And a UK study from 2 years ago of 160,000 women age 40 to 50, they randomized half of those patients to get a mammogram once a year, the other half to wait until age 50. And that other half only got a mammogram if they developed a breast mass. And what that study showed is that it reduced the risk of breast cancer death by 25%. And there's a hue and cry in the UK because they're still sticking to the starting at age 50 every other year. I think that that's likely to change going forward. Additionally, that UK study showed that doing a yearly mammogram reduced the need for mastectomy to cure patients, and it reduced the need to use chemotherapy. So doing mammograms earlier gives patients a better chance to find a smaller cancer and to avoid bigger surgery and also chemotherapy. And it also gives you a couple more chances to find the more aggressive breast cancers, such as the triple negatives and the HER2 positives. So I just want to review again the difference between a screening and a diagnostic mammogram. Screening mammograms are 2 views done for patients without symptoms. Diagnostic mammograms are for patients that have breast pain or that have a breast mass, and those are 4-view mammograms with magnification views and a diagnostic ultrasound. So we spoke tonight about risk factors for breast cancer. This is a disease of lifestyle. It's, very rarely a disease of hereditary. And we talked about the time that it takes for breast cancer to develop, and also when mammograms should start and how frequently they should start. Thanks for your attention, and I'll be available for questions later. Dr. Dennis?
Thank you. I love it when I learn a lot from these lectures, which I just did. Our next speaker is Dr. Clark Fuller. Dr. Fuller, as I mentioned, is a cardiothoracic surgeon. He got his bachelor's from University of Wyoming and medical school at Creighton University in Omaha, then a general surgery residency at University of Missouri, followed by a residency in cardiothoracic surgery at USC. He finally discovered the good weather out here. And also Children's Hospital. He then completed additional specialty training fellowship in esophageal surgery at USC and a second fellowship in thoracic surgery oncology at University of Texas's MD Anderson Cancer Center, which may not have as good weather, but it's pretty darn good cancer center. Editorial. This is my personal opinion, has nothing to do with TMMC. Please don't. Dr. Fuller has also authored many books and many numerous articles and is still active in research. Dr. Fuller.
Thank you very much for that introduction. Every time I hear that, It reminds me why I was 37 years old when I got my first job. That my mother, still 96 years of age, reminds me on a daily basis. Another thing I need to clear up is for people that are viewing this and may have this handout. In this picture, yes, that's me who's giving the talk. You're not getting this guy's dad giving the talk, and that's not my son. It's one and the same. I definitely need to update that. And you'll also notice that I will be giving this talk without the benefit or of slides. I learned a while ago that I tended to read the slide and reiterate what was up there, and I prefer to talk to you, the patient, the educator, the person that took the time and effort to come here. I also think back that both my minister and football coach never used slides, and I remembered what they said. So maybe there's a message there, right? I was given the Herlichian task today of talking about lung cancer and trying to wrestle that down into something that we can. I want a few take-home points that in this 15 minutes that I'll be able to have. Dr. Chan did a marvelous job of doing that with breast disease, and I'll see if I can emulate that. I think one of the most important things we can talk about tonight is identifying the problem itself. I mean, when we say cancer of the lung, I want to be clear that this remains the #1 cancer killer, not only in the United States, but across the world. In fact, because of the success we've had with other disease, lung cancer is responsible for more deaths than breast, colon, and pancreas combined. Okay. It's also not a disease just of those people that smoke. That's been very convenient. We think, I don't smoke, I can't possibly get it. That's not, unfortunately, is not true. As a matter of fact, of the new cases, of the over 200,000 new cases we see every year, over 15% of those are never smokers. And of that particular population, greater than 60% are women. So there is a very interesting dynamic that is going on here. Cigarettes were given to our troops in World War I, and not surprisingly, lung cancer, a relatively rare disease prior to that, escalated. Women, it remained rare until about 10 years after World War II. And I'm reminded of there was a cigarette branded towards women called Virginia Slims. And their slogan was, "You've come a long way, baby." And you really have, because now you're doing something much better than men. We are now seeing more cases of lung cancer in women than men. We also want to know that who knows where we're going with this, with the advent of vaping, the legalization of marijuana. I'm often confronted, people say, well, it's natural, it's it grows and it's organic. And I need to remind them that so is tobacco. It too, it's a product of combustion, either evaporation with the vaping or combustion. We know that there are over 200 known carcinogens in the smoke of marijuana. So I think that we are, this problem, although cases of lung cancer due to smoking may be in a decrease, overall, the case number is expected to rise, particularly with the earlier age that both those habits tend to be adapted to. Lung cancer, we've paralleled a lot of our attempts and success at what's been done in the breast world. You'll notice that when I talked about cancer deaths, I brought up colon and breast and prostate. I think I said pancreas, but I meant prostate. Mostly because those three all are associated with a pretty darn good screening test. Lung cancer never had that. And what happened is that people were diagnosed, were found to have the disease way late in the progression of it, by the time symptoms presented themselves. And when people present to their physician complaining of cough, weight loss, blood in the sputum, over half of those have widely disseminated disease. And medical science, whether it be chemotherapy, surgery, unfortunately had little to offer that patient. So we needed a screening test like those other three had. Fortunately, About 10 years ago, there was a trial called the NSLT, the National Lung Cancer Screening Trial, that did in fact prove that with low dose screening CAT scans, and this was directed towards a specific population, ex-smokers within a certain amount of years of quitting and of certain age, it did demonstrate a greater than 20% reduction in mortality secondary to lung cancer. And this is for the very same reason that we saw mammogram. What mammogram was to breast disease, the CT scan was to lung disease. It shifted that paradigm from finding a larger, palpable tumor to something that we could deal with at a much earlier stage. And when we say stage, we mean extent of the disease, where it is and where it's not. And the ET scan changed that. It began to move. That was the inertia that really began to change things. It's been further refined and to expand its application to a broader pool. And I think that that's going to continue, particularly when I give you the statistics of the non-smoking patient. Women are of particular interest to me of this because of the no known exposures to it. And also because most women up until the age of 50, most of their primary health care comes from their obstetrician. And we need obstetricians. I love obstetricians. I had one deliver both my boys, but they're not cancer specialists. They're not people that have that global idea. So there's a huge need for education, both within the patient population, so they can be an advocate, as well as within the physician population, just in education. So screening has become. I'm proud to say that at this hospital, there's a very active screening process that we have incorporated into our weekly tumor board. And I'll address that more a little bit later. The next aspect I want to talk about is technology. Then once we have this, what do we do with it? And that's technology is also, we've found that it's very important that from the time of diagnosis to the time of treatment needs to be shortened dramatically. Matter of fact, if anything came from the COVID experience, it was that we know already that delays between diagnosis and treatment alter eventual outcomes. So what we're using is incorporating our technology to shorten that duration. And again, that's something that's very important that we have here. The way we incorporate that, probably the most meaningful, is a weekly tumor board that as a collection of physicians who specialize in the treatment of cancer of the lung, or I should say thoracic malignancies. We meet every Friday here from each discipline: pathology, radiology, surgery, oncology. And cases are presented both in what we call a prospective, which means there's an ongoing decision-making process that all the fields meld together to produce a treatment plan. We also do what we call a retrospective, meaning some treatment has already occurred, and we're looking back to see what either further needs to be done, could have been done better, and what we should do in the future. Technology in these really helps us in treating cancer patients, particularly of lung cancer disease, is, like I said earlier, the extent of the disease, meaning where it is and where it's not. That is the driver to what we do. It not only drives what we do, but the sequence or the order that we do things. Is it surgery alone? Is it surgery plus chemotherapy and radiation? Should chemotherapy and radiation precede surgery? There's a Rubik's Cube there that gets turned with each one of these patients, and it's invaluable to have the people making that decision in the same room at the same time. And then a treatment plan comes forth to that. And rather than the patient going through a series of different appointments, that is greatly shortened and a consensus is obtained, and we feel that the best possible care is thus a product of that. What I'm especially proud of here is the surgical approach to the disease. Surgery has a very prominent role in the early stage disease, and when you have an active lung cancer screening program, that needs to be a viable component to it. And it's not just the operation itself, it's how we do it. What is unique to this hospital and what's been recognized on a national level as well, that we have a high-performing division here, is that over 95% of our cases will be done with a minimally invasive approach. And when I say minimally invasive, traditionally access into the chest cavity was gained through a large incision on the side, a rib was potentially removed, and the patient spent the next 6 months recovering from that. Lord knows if they needed anything else after that therapy, which half the patients couldn't tolerate because they were recovering from the operation itself. When I was at MD Anderson, that was the standard of therapy, and you do that 5 or 6 times a day. Your service in the hospital becomes enormous, and I saw that it took a long time for these patients to recover. With the advent of what we call video assisted or robotic assisted, both those are just methods of gaining access into the chest cavity through little incisions and using a TV camera to see what you're operating on. And trust me, I think Dr. Linnebur will support this, that we operate the very best when we see things the very best. And these video assisted approaches, whether it be with VATS or the robot, afford exceptional exposure and visualization of what we're doing. So we've been able to adopt and go from an open procedure with approximately 7 to 9 day hospitalization, a 6-month recovery, to an average of 2 days in the hospital and approximately 2-week recovery. It also greatly enhances, matter of fact, the patients that need therapy after their surgery, over 90% are able to complete it, not just initiate it, but complete it. And I think that's a dramatic improvement, a testament to a patient I just had. We operated today. I saw her before coming over to this meeting, and she asked if she could join us. And I almost thought about it. That would have been really interesting. But it's a huge step forward. And the most important part of it is that it does not compromise the positive effect of the operation itself. It doesn't make any sense. It just becomes a pony show if you do it, but it doesn't change that. It does not. Our survival is as good as or improved upon than when done with an open procedure. The future here at TMMC, I think, is indeed very, very bright, in that where we've come is great, and I'm pleased with it. But there are still things that we're going to be able to incorporate. Having a cancer center, a real, tangible cancer center in place that has embraced what I think are the pillars of success. With that, number one is that we have a multidisciplinary tumor board that meets consistently and effectively. Number two is that we have specialized treatment groups that has been set up, that there is accountability and specialization that exists. And there is one that encompasses lung, encompasses breast, and encompasses colon. Three is every patient that comes through here is going to have exposure or a chance, perhaps if need be, to be enrolled in a clinical trial. And that's a bedrock of success, because we don't make any progresses unless we're actively involved in those. We don't learn unless we explore. And the last thing is we've got an environment that's interested in investing in and advancing the technology that we have here. We are going to open up here in the next month an incredibly exciting technique, whereas through our screening process since 2016, we have evaluated over 700 nodules or abnormalities that we've seen on a on a CT scan that otherwise would have been not talked about. Through that, we decide which ones represent a high risk of malignancy, which ones can be safely observed, but getting that diagnosis remains mildly difficult. What we are bringing here is a tool that's going to greatly enhance our ability to make a diagnosis of a smaller nodule in the lung that is almost impossible to reach, either with a needle from the outside or with present-day techniques. It embraces the same robotic technology that we have here, except it makes use of a virtual system and it recreates the airway and allows you to navigate a bronchoscope with a biopsy forceps all the way out into the periphery of the lung into a very small mass with a highly sensitive biopsy that will tell us not only if it's cancer or not, but more importantly, convincingly tell us when it's not a malignancy. And that is a real plus to have, is a test that tells us not only what it is, but can consistently tell us what it's not. And that's sort of the thing. And combining that in, doing it all at one time, having a patient that we see here with an X-ray, we think it's a high risk. I take him to the operating suite. We make the diagnosis, and right then and there, we deliver the surgery as well. We call it single anesthesia bronchoscopy and resection, or SABR. And that's the kind of, remember I talked about at the very beginning of this, that duration between diagnosis and treatment. It doesn't get much closer than that. I would also end with this final note, is that building a cancer center like this here is extremely important, and supporting it and fostering its growth, because 80% of people, when they hear the word cancer, they look locally first. And if it's here and we're ready, and I firmly believe that's what exists here at Team MMC, I think that whether it be breast, colon, or lung, I think that is a substantial gain, and it's something the community can be very proud of. Like David, I will entertain, look forward to questions. It's an enormous topic, and if nothing else, I hope that there's a few points that were made that are able to be taken home. Thank you very much for your attention.
Excuse me. Thank you, Dr. Fuller. Again, I'm just amazed how much I didn't know till I came to this. Dr. Megan Linnebur is a California native who lost her way and went back to Virginia, but she got her undergraduate degree at College of William and Mary and medical school at New York Medical College in Valhalla, and then discovered the good weather again at LAC-USC, which is Los Angeles, of course. She completed her fellowship training in colorectal surgery, board certified American Board of Surgery and American Board of Colon and Rectal Surgery, and is now, what type of dancing was that I saw in your resume? And is a traditional Peruvian dancer. And I say that actually because I think it's extremely important that physicians have outside interests. When I take a look at the tremendous burden that medicine imposes and the desire to always be on the clock and be trying to do as best as you can with your patients. We probably won't talk about this so much, but I just want to put a pitch in for having a balanced life and how important that is. And physicians are often accused of not having a balanced life. So that was meant as a compliment. Anyway, without further ado, Dr. Linnebur.
Thank you very much. My mom will love that shout out because she's the Peruvian one. So we're going to talk about colorectal cancer. So it's the fourth most prevalent cancer. I was supposed to be the fourth one going. It's the second leading cause of cancer deaths in the United States. 1 in 25 people. So sorry, Dr. Fuller, I'm going to read a little bit off my slides, but try to talk on top of it. 1 in 25 people will be diagnosed with colorectal cancer in their lifetime. That's 4% of people. The highest risk is in non-Hispanic Blacks, and it affects men and women equally. So to give you a little background, just so as we go forward, the stages of colon colon and rectal cancer. So we say colorectal, colon, rectal. Colon cancer is treated differently than rectal cancer, but generally the stages are the same. So it can be localized where the cancer itself, the tumor is in the colon or the rectum only. It's more advanced stages where it's invading nearby organs like the bladder or some of the other intestines, the vagina, the prostate, or there's lymph node involvement. And if the cancer has spread, that's called metastatic cancer. And this cancer specifically can spread to the liver or the lungs. So overall, the survival rate is 65%. In the mid 1970s, the survival rate overall was 50%. So we have come a ways in terms of our screening and our treatment of colorectal cancer. And you can see there's a little graph here showing the different survival, 5-year survival rate by stage. So the earlier stages actually have a very good survival rate, 91%, 73%. When you get to the more distant stages, it's still not great, 15%. The most common cause is a polyp, just a polyp that you get normally. No, this is the average risk patient. We'll get into some of the other risk factors, but it's an abnormal growth that you get inside the intestine, starts to grow. Eventually, these cells become abnormal and it can turn into cancer. And then it starts invading through the colon wall, maybe to other places. There's about a 10 to 20 year natural progression of a polyp. You can have it for 10 years before it ever turns into a cancer. That's why you hear, oh, I had a colonoscopy, I'm good for 10 years. That's the average risk patient. They're very common. About half of the people who are older than 50 years old getting a colonoscopy will have polyps, but only about 10% of these polyps will ever progress to cancer. And the larger a polyp is, anything over 2 centimeters, there's a higher risk of cancer. 2 centimeters is like almost a little smaller than 2 of my fingers, my thumbnail. I don't know, I have small hands. There's other hereditary syndromes. This is a smaller percentage of colorectal cancers that have a hereditary cause, like Lynch syndrome, which can be associated with other cancers, like bladder cancer, uterine cancer, polyposis syndromes, patients who have hundreds of polyps or thousands in their colon. They can also have polyps in other places like their stomach. Those patients are at higher risk of having a cancer in any one of these polyps. And the BRCA gene, sorry, I got distracted by these questions here that I'm seeing. There's about 1% of these patients that will also have colorectal cancer. If you have a personal history of polyps or cancer, or if your family members have a history of polyps or cancers, you are at higher risk of having polyps and cancers yourself, especially if it's a first-degree relative like mother, father, children, sibling. And then, as Dr. Chan mentioned, chronic inflammation can lead to higher risk of cancer as well. Inflammatory bowel disease like Crohn's disease or ulcerative colitis, these patients have a higher risk and they get screened more frequently. Some of the other causes are diet and lifestyle. We're seeing a theme here. These are things you can control. You may not be able to control hereditary causes, family history, but you can control diet and lifestyle. So eating refined carbohydrates, processed sugar, red meat, and processed meat, these are all causes of an increased risk of colorectal cancer. In 2015, the International Agency for Research on Cancer classified processed meat as carcinogenic to humans and red meat as probably carcinogenic to humans. There are studies that show this association with colorectal cancer, and not just cancer, also with diverticulitis and recurrent episodes of diverticulitis. Obesity, smoking, and an increase in consumption of alcohol is also a cause. So prevention is key. Nutrition, eating a plant-based diet, whole grains, fiber, this decreases your risk of developing colorectal cancer. Having a healthy lifestyle, smoking cessation, decreasing your alcohol consumption, and increasing your physical activity, as well as regular screening tests. You can say that colonoscopy prevents colon cancer because colonoscopy, the gold standard, is a way that you can remove a polyp and prevent it from ever turning into a cancer because you have removed it from the colon. So this is a test where you prep with laxatives. You clean out your colon so that the doctor can see, and you get sedation during the procedure, and they insert this long flexible tube into your colon all the way to the end, and they look at all the inside of your colon. And if they see anything like a polyp, it can be removed. So it's not only diagnostic, but it is also therapeutic. There are other screening tests like a flexible sigmoidoscopy. This isn't done as much anymore, more in favor for the full colonoscopy, but a sigmoidoscopy is pretty similar. They just look at the lower part of the colon. They don't go all the way to the end. There's a special CT scan that can be done in special circumstances. And what you hear about now are these stool tests. So there are stool tests that detect only blood in the stool, and maybe blood that you can't see, and they're blood products. And there are stool tests that detect both blood and altered DNA from polyps or cancer that is shed in the stool. Cologuard is one of these. Depending on what stool test you do, you may do this every year or every 3 years. The important thing to know that these stool tests are only for people who are at average risk of colorectal cancer, meaning you don't have inflammatory bowel disease, you don't have a family history, and you don't have a hereditary disorder. And it's a patient who has no symptoms. We'll get into that. Any positive test should be followed up with a colonoscopy. Any bleeding is abnormal and should be evaluated by a colonoscopy. I put this in bold because I cannot tell you the number of patients I have that come to my office to see me for bleeding hemorrhoids. And they say, I haven't done a colonoscopy, but I had a stool test and it was negative. But you're bleeding, so you need a colonoscopy. Now, if you've had a colonoscopy recently, that's a discussion with your doctor. You know, if you just had one last year, it's probably your hemorrhoids, okay? But you need to be up to date on these screening tests. So besides bleeding, which could be red stools or black stools, other changes in your bowel habits are important reasons to undergo a colonoscopy. You may get constipated or have thinner stools. You may be having diarrhea, which was never normal for you before, or urgency where you're running to the bathroom. Any changes should be something you bring up with your doctor and see if you should have a colonoscopy. Abdominal pain, weight loss, and unexplained anemia. And anemia means a low blood count. That could be you feel fatigued, you feel short of breath. These are reasons to look for polyps or a cancer. So you can see in these pictures, polyps can take many forms. Some of them you can barely see. They're very flat. Some of them are rather large, and you could imagine that some of these can get very large before you may have symptoms. And again, during the colonoscopy, you not only see this, but these can be removed during the test. Classically, the screening was recommended to start at age 50, but new guidelines came out in many of the societies. They were very rapid to adopt them because there was an increased prevalence of colorectal cancer in young adults, probably due to lifestyle diet changes that are leading to higher risks at younger ages. It's not necessarily hereditary causes. So now the new guidelines are to start screening at age 45, and you continue your colonoscopies until the age of 75 or 85, just depending on your medical fitness to have a test. I put a picture here of Chadwick Boseman. He's probably the most prominent person I can think of in the news. A couple years ago, he was diagnosed at age 40 with stage 3 colon cancer, and unfortunately, he succumbed to his disease in 2020 at age 43. So if you have risk factors like a family history, inherited disorder, inflammatory bowel disease, you start your screening before age 45. And when you repeat, in general, any colonoscopy depends on your risk factors as well as the number of polyps, the size of the polyp, and the type of the polyp. If you are diagnosed with colorectal cancer, colon or rectal cancer, there are several modalities that we can treat it. There's chemotherapy, there's radiation therapy, which is generally reserved for rectal cancer. This is where the treatments differ, and there's surgery. These depend on many factors, which is too much for our scope of our talk today, but it depends on where the cancer is in your colon, where it is in the rectum and how far it is from the anal sphincters. It depends on your stage, and it depends on patient factors, your other medical problems as well. Surgery is done minimally invasive. Yes, I am an advocate for robotic surgery, minimally invasive surgery, because it gets patients out of the hospital more quickly with smaller incisions, less pain, and you can see way better. Most surgeries are done minimally invasive. Most patients are out of the hospital in 2 to 4 days. You're walking, drinking liquids the night of surgery. And most patients do not have the number one question I get, a colostomy bag. Okay. That's when your colon is stitched to your abdominal wall and the waste comes out in a bag. There are some situations where this may be necessary, whether it's temporary or permanent. But again, this is a discussion based on many factors and with your team of doctors. So there are many clinical trials of which we are participating in many of them. There are new studies that are looking at special therapies, immunotherapy, where they can target the genetic abnormalities in the cancer. Overall, the treatment is a team approach. It is very much centered on the patient. Again, like I said, there's many factors we take into account based on each patient, and it's a shared decision that we make together as a team. As Dr. Fuller said, they have tumor board conference. We have that every week for the GI cancers, meaning the colon cancers, pancreas, liver, and the breast cancers, where all the doctors are present from all the specialties. The most important thing, if you take anything out of my talk, is that prevention is a huge factor for colon and rectal cancer. Get your colonoscopies. If there's no contraindication, this is the best test. I know we have a stool test giveaway, but please discuss with your doctors what is the right test for you. And that's my group.
So the only presentation I think that didn't stress diet was Dr. Fuller's. So did you want to just chime in that diet's important too for lung cancer? Because I think that, again, the theme of our presentation was we said we were going to talk about preventing cancer, learn what you can do. And I want to make sure that people understand that cancer is not a hopeless diagnosis, and it's not inevitable. If you have parents with cancer, it doesn't mean that you're going to have cancer, but you have to start thinking about how to prevent it. Sorry.
No, excuse me. Yeah, I would echo the sentiments to my left and to my right that diet, although we don't see a direct cause and effect with cancer of the lung, it certainly influences your recovery. I'm reminded of something that I often hear from my wife, who's a pediatrician. She goes, my job is to prepare and prevent. Your job is to react and repair. And I'd much prefer if you prevent it. And I think that diet with any of these is an excellent means of prevention.
Thank you. I had a question that has been in my mind, and looks like it's a part of number one question. I'm going to ask each one of you in turn. We've talked about diet. How about supplements? What is the role, if any, of supplements in terms of either people who already have cancer or people who are trying to prevent cancer? So I'll start with you, Dr. Chan, since you were the person the question was directed towards.
I think the data is very clear that taking vitamin supplements is not better than ingesting fruits and vegetables as part of the diet. Paul Offit is a very famous professor at UPenn, and he wrote a review article for the New York Times about a decade ago. It was called "Don't Take Your Vitamins." And what he did in that article was review all of the prospective randomized studies with multivitamins versus taking placebo. And all of those studies showed in the multivitamin group a higher cancer risk and a shorter survival risk. And the supposition is that we need to have oxidation in our bodies to eradicate viruses, bacteria, and rogue cancer cells. And if we're taking a ton of antioxidant supplements, we're impairing that. And I think the USPSTF recently echoed that in guidelines that came out this year, where they gave it a D rating in terms of taking multivitamins. There's certainly situations where multivitamins are necessary, patients with gastric bypass surgery, short bowel syndrome, patients with macular degeneration, but by and large, you can't do better than eating fruit and vegetables. And so I tell my breast cancer patients, they really need to focus on weight management, exercise, and eating fruits and vegetables. There's no shortcut pills to that. The only exception I make is vitamin D. I think if you look at the average vitamin D level in the United States, it's in the teens. There are studies from UC San Diego showing that if you have a vitamin D level between 40 and 60 or 40 and 70, you have a lower cancer risk. Higher vitamin D levels seem to reduce insulin resistance and also help a T cell function. And you can't get D in the diet. And since we're not farmers and fishermen and hunters anymore, pretty much we're all D deficient.
I will echo that. There are some studies for colorectal cancer. It's not definitive that vitamin D supplementation decreases your risk of colorectal cancer. And I agree. And there's a lot of studies looking at the best prebiotic and probiotics are in the fruits and vegetables themselves. And maybe tree nuts for colorectal cancer also decreases your risk.
Perfect. Can we scroll to the first question? Okay. Actually, the question was regarding the supplement nicotinamide riboside and increasing breast cancer risk. I think let's come back to that one because it is probably a marginal question. I think there are other ones that are just a little stronger. Other than smoking, what other risk factors for lung cancer are there?
There's been shown that particularly in the Asian population, that a first-degree relative may in fact increase a risk that also may be related to secondhand smoke exposures within the home, and that includes cooking smoke. That was studied and looking at cancers in non-smokers in Taiwan, and that became one of the risk factors. There's been radon gas, radon levels in basements in the Midwest. There's a host of minor things that can be addressed, but by far and away, 100%, it's exposure to a combustible product, whether it be tobacco or elsewhere.
Can I ask a question about that?
Sure.
So if we buy a house, are we supposed to get it radon tested?
California, I think it's really low, but I was properties elsewhere that I've looked at. Yeah, it becomes part of the deal.
My understanding is the radon typically leaks out of the ground soil. Mm-hmm. So we don't have basements typically here in California, and we tend to leave our windows open too in the winter. So we do get some air circulation. So that reduces the risk. But the other one that I've seen is air pollution. And not living within, 500 or even 1,000 feet of a freeway or a major road as a risk factor in developing not only lung cancer, but perhaps even diabetes and cardiovascular disease and other things because of the inflammatory effects of the pollution.
It seems incomprehensible to me that could not possibly add to it. I would agree. And then you get a mixture. It's a witch's brew of who knows. And then a lot of these things that we inhale can remain deposited and stay within the airways for an inordinate amount of time and never gets cleared because our lungs were never designed to clear themselves of the heavy residues and things that are in the air and part of the pollution process.
Thank you. We have actually two questions on mammograms. So when do you stop getting mammograms? And the sub part was, what if you're a breast cancer survivor? Do you ever stop getting mammograms?
Yeah, I think you stop getting mammograms when you get to a point in time where you are too ill or too elderly to have breast cancer treated. So, California is different than Iowa. A lot of our women are, healthier here. And I think that the general recommendation is that you stop mammograms like at age 80. I've seen plenty of patients that are in their 80s with breast cancer. I have a breast cancer patient that's 94 that every summer she drives down to Del Mar to see the races, stays overnight with her daughter and drives home. I mean, she obviously should be getting breast cancer treated. I have other patients who have multi-system illnesses on dialysis, diabetic eye problems and things like that. And that patient might not benefit from getting a screening mammogram. Our breast cancer patients continue mammograms yearly. We no longer do every 6-month mammograms on our patients that have lumpectomy. I think the data shows that it's not helpful, and primarily it's because our surgeons and radiation oncologists are so good that the recurrence rate is so low that it really isn't worthwhile. So we're going once a year, and that's pretty much the standard.
Going to switch gears a little bit, and this is an open question. Any stats to date on cancer due to marijuana? And I think probably each one of you might have some idea. At least impressions. We're going to allow people to have impressions without having to quote studies, because I think often what's important is that we try to get the message out sometimes before there are 10,000 people enrolled in a study for 5 years or 10 years or 15 years.
Yeah, and I think that's exactly the case in point here. Is I'm not sure that we need a study, to tell us you put your hand on an oven and it burns, that you shouldn't do that. And I think that it's fairly evident that a combustible product that we know that the smoke has been analyzed, it has known carcinogens in it, it comes from a source that is not even remotely controlled, that it's, and the whole idea of inhalation and holding it in as long as you can, as deeply as you can, are the real problems with cigarette smoke. Matter of fact, it's probably why with a filter, because it requires the person to inhale stronger to get the smoke through it, have probably been more responsible for lung cancers than the filterless, the old, roll your own kind. But I think it's. I don't think we need a necessary study or a warning on a pack to tell us that it's an issue. Will be.
I will take a different route to address this. Though smoking is a risk factor for colorectal cancer, most of the studies about marijuana and colorectal cancer that are coming out now, and they're talking about it more in conferences and doing studies, are more of the effect of marijuana or CBD on things like your tolerance to anesthesia, how to manage your pain after surgery. These are more the factors that I'm seeing from my standpoint in colorectal surgery. Patients who do use marijuana and marijuana products, whether it's edibles or ingesting, they tend to have a higher need for larger amounts of anesthesia. They have a higher pain threshold. They need more pain medication after surgery. I think that there's going to be a lot of studies coming out on the benefits of CBD, but not necessarily THC, which is the psychoactive. And clearly smoking is not the way to do that. So I think there's going to be more studies on that, but that's kind of what I'm seeing, but not really smoking marijuana and the risk of colorectal cancer.
Interesting. Getting back to breast cancer, what percentage of men get breast cancer, and what type of breast cancer do they get?
Breast cancer is very rare in men, and they get basically invasive ductal cancers. And, I've been doing this for over 3 decades, and I probably have seen maybe 7 or 8 men with breast cancer. I probably see 200 women a year, or sometimes 300 women a year with breast cancer. So it's a very small number. Those men typically also have BRCA mutations, so they have an inherited risk as well.
So that kind of introduces a topic that I think was touched on by all of our speakers, but I know is of great interest, which is, what is the role of this genetic screening in your particular type of cancer? I just want to emphasize this because I sit in a catbird seat at TMIPA. I handle all of the medical approvals and denials. So all the requests for complex genetic testing end up on my desk sooner or later. And there's no question that over the last 3 years, I've seen a significant increase in the requests for genetic testing. And then I think actually it was one of the members of our MOL committee that mentioned that she had come across a direct-to-consumer genetic test, which wasn't approved by the FDA, but was being marketed directly to people to determine their risk of cancer. And if you could talk about also too the risks of genetic screening from the standpoint of lack of sensitivity and specificity.
Yeah, so I think it's become standard of care that genetic testing for inherited cancer be done in pancreatic cancer patients. About 10% of those patients, maybe 15%, have an inherited gene, and also in ovarian cancer. I can tell you that every breast meeting I go to is recommending that genetic testing be done on any patient with breast cancer, because if we follow the current guidelines in terms of age and family members with breast cancer, roughly half of all the inherited breast cancer genes are being missed. So the way the testing should be done is not through direct-to-consumer testing. Testing companies like 23andMe are direct-to-consumer tests, and they test what are called genotypes. And of the BRCA genes that they discover, that they can test for, it's really the 3 genes for European Jewish ancestry that have BRCA mutations. That test miss about 999 other BRCA mutations, and they miss all the rest of the panels that are found on gene sequencing. So if a genetic test is being done for cancer, it's got to be gene sequencing. And I've had patients with BRCA mutations. I asked them, did you get your daughters tested? They said, yes. I said, I want to see the result. And they bring to me a 23andMe test, and I have them get gene sequencing through a company like Invitae or Ambry, Tempus. And I found more than a few of those individuals that thought they were BRCA negative actually turn out to be BRCA positive. The good thing about the gene sequencing test is that if you're a patient with cancer and you have that mutation, it shows a higher link to cancer risk. That company will do the testing of the rest of the family at no charge. So it's really a service. And so I think that we're going to see the price of testing drop, and we're going to see more of the testing being done simply because we're identifying more and more genes every couple of years. Maybe Megan can talk about Lynch testing.
Yeah, so every cancer that is found on colonoscopy, now the standard is the pathologist will automatically test that for Lynch syndrome. Lynch, it's a little more complicated than that. They test for the absence of certain markers in the gene of the cancer, and if certain ones are positive or missing, then you know that person has Lynch syndrome. And sometimes that involves additional stages of testing, just depending which one of these 4 markers are absent or abnormal. So once you know you have Lynch syndrome, if you're the one who already has the cancer, you're screening after surgery. After any colon cancer surgery, you get another colonoscopy a year later, and then, about 2-3 years later, and then every 5 years. But if you have Lynch syndrome, then it's more helpful for your family members to know when they should start having colonoscopy screening, because your children, if they're 15, 16, they should be having colonoscopy in their 20s. So every cancer, colon or rectal cancer, is automatically sent for Lynch syndrome testing.
Could you just basically explain to us what types of cancer fall under that category of Lynch syndrome?
Yeah, so generally the other ones that are associated could be a bladder cancer or uterine cancer. So sometimes there's a discussion with women who still have their uterus to do a hysterectomy at the time of surgery. And thyroid cancer is also one of them. So your oncologist, should talk with you and your primary care about screening, when to do an ultrasound for your thyroid and to do your pap smears, although that's cervical, and to take a look at these other things like your bladder, you doing urine tests and things like that.
So Dr. Fuller, could you tell us where we are with genetic testing for lung cancer? Wow.
I think it falls under two headings. There is certainly, we have a national, it's called the National Community Cancer Network, that issues it's a consensus on how to approach various stages of cancer, and people that have had repeat or have multiple synchronous cancers are referred for genetic testing. And I think that's more information for their families, as well as a first degree relative, as I said earlier, can certainly have a higher risk without the known exposures that we've talked about. I think it's also important when you talk about this kind of all gets lumped together, that we are looking at specific gene sequences that also allow us to have what we call targeted therapies nowadays. And that's a whole nother science, not so much related to familial and looking at cause, but enabling us to treat. And that's something that's expanding rapidly, and that we use extensively here in all forms of this disease.
Yeah, so there's 2 types of testing. One is for inherited disease, and the other is looking for therapeutic targets. And as Clark said, in lung cancer now, roughly 35 or 40% of patients have a target that is amenable to small molecule oral pill treatment. It's really changed the landscape of patients with lung cancer. The survivals are dramatically increased, and we have some patients with untargeted treatment that are alive, 5, 6, 7 years taking a pill. They, previously they would have maybe survived a year and a half with standard chemotherapy. So it's an ongoing field, and we're going to see a lot of it. And pretty soon, I think we're going to be pretty much doing molecular testing on a lot of patients with cancer.
And to kind of further, even to build on what David said, is that we're actively going to participate in a trial here, speaking of clinical trials, where we're looking. We know we talked about screening and finding disease at earlier stage. And unfortunately, in cancer of the lung, almost a third of those patients, even at early stage, will develop distant disease. And so now we're using this genetic testing to look at which one of those early stage patients are at high risk of developing eventual disease elsewhere. And maybe that patient benefits from either chemotherapy or a targeted therapy to prevent that from ever occurring in a patient population that would not normally receive it. And that's something we're going to be doing here as well too. So when you say when genetic testing gets brought, it's a huge field to dissect.
Next question was directed to Dr. Linnebur. At what age are colonoscopies no longer recommended, or is there such an age?
So they're generally recommended to continue until you're 75 to 85. Most guidelines will say 75. But again, speaking to what Dr. Chan said, if you are a very healthy 75-year-old, I have seen patients in their 90s. I have operated on patients in their 90s who stopped getting colonoscopies when they were 75, and now they have cancer. So this is a discussion, with your doctor, because if you have other health problems where you can't tolerate a colonoscopy, that would probably not be recommended for you to continue beyond a certain age, but generally the age is between 75 to 85.
Is recommended colonoscopy at age 45 approved with insurance?
Yes, it is also approved earlier. If, say, you were 40 years old, you have bleeding, rectal bleeding, and no other symptoms, colonoscopy would be indicated and covered by your insurance because you are having symptoms. You are bleeding.
I just wanted to make a comment about colonoscopy. I was thinking while you were talking, Dr. Linnebur, I'm old enough to have been in the early stages of when colonoscopies were definitely an ordeal. You had to drink like 2-gallon jugs of this terrible salty solution that it was hard to not throw up with it. And then you didn't get anesthesia too. So when they inflated your bowel with gas, it was the worst gas cramps you ever had. It has changed dramatically. It is not traumatic to take the PrEP. And in having propofol is rather unique. You say bye-bye, and then you wake up and you didn't even sleep. Like sleeping, you get a sensation of time passing. With this, it's boom, boom. They just happen. And, while they won't let you drive when you've got the propofol, you can, because you're alert and you're ready to go. It is not traumatic. Please don't anyone refrain from getting a colonoscopy because they think it's going to be an ordeal. It is not an ordeal. It's life-saving.
So thank you for bringing that up, actually, because yes, before you got the big jug and you got to drink this in one day and, oh my God, how can I possibly drink all that water? Now it's much less volume. Generally, it's Miralax and Gatorade with some pills. There are other formulations, smaller volume, and even some pills, some that are just pills. However, these newer ones, like the pills, are still very expensive. So that is somewhat prohibitive. But yes, the risk of a complication from a colonoscopy is very small. Generally, they are very well tolerated. If you looked at the schedule, there's 20, 30 more people having a colonoscopy every day. So it is very safe. The bowel preps are different. They are more tolerable. And again, something to discuss with your doctor who's going to be doing your colonoscopy about your different options.
Well, this one I think was probably directed at our missing member. My father once told me that if any man lives long enough and nothing else kills him, eventually he'll get prostate cancer. Is this true?
Yes, it's true. So autopsy studies in 80-year-olds show that 80% of men have some element of cancer in the prostate. It's never affected their lives. And that led to the big controversy in terms of whether PSA screening saved lives, who should get PSAs. The USPSTF guidelines misfired on that again and recommended against PSA screening. There are many studies now, including the recent VA study that was published last month that showed that getting PSA screening does save lives. And I think the thing about prostate cancer is that not every man that has prostate cancer has to have treatment for it. A lot of men have low volume, low grade disease, and they go through a program called active surveillance, which is not ignore. They have PSA testing. They have periodic biopsies to see if things change. And some men go, decades without needing treatment. So yeah, it's true that that prostate cancer is very common as we age.
I want to just give a study, N of one, as we call it. So one person, a very dear friend of mine, got a PSA done at age 40 and it was elevated. He is still alive today, and he's as old as I am, which is definitely put on quite a few years because he got that PSA screening. He at that time, he absolutely did not qualify for it. And so I think this is definitely, if your insurance, quote, doesn't cover it, this is money well spent to get a PSA screening if you're, quote, too young. And unfortunately, I see that because I see all the not only the clinical reports from the physicians, but I see the criteria that the health plans impose, and some of them absolutely don't make sense in terms of what they are going to allow. And it's unfortunate, but again, you only have one life. And what's more valuable than your life? I don't know of anyone that thinks that with any sanity that thinks that there are things that are more important than life. Are there any studies that mention the amount or intake of meat or processed meat consumed daily or weekly that increases the colorectal cancer risk?
So the study that was done on that, and for diverticulitis, they just compared people who ate large amounts with small amounts. It's kind of hard to quantify. But if you read a lot of the literature, red meat and processed meat, and I mentioned the diverticulitis to say it's not just cancer. Think about it. It's anything you're putting in your mouth, that you're then evacuating, is in your entire gut, touching all of your gut lining. So how can diet not affect colorectal cancer? I could go on a diatribe about this for hours, but the main point, and I tell all my patients, and I think the oncologists also reinforce this as well, is eat more plants, fruits and vegetables, whole grain, fiber, and reduce or minimize, or if you can, eliminate red meat and processed meat. So if you're, somebody who, I guess to kind of answer the question a little more directly, if you're somebody who eats meat, 3 times a week, and you say, well, I just can't completely eliminate it, do it once a month, once every other month, make it that special treat, but really minimize it. That's my recommendation and the recommendation based on studies.
I remember hearing a news report that said that somebody had taken this to the ridiculous, and they said that one slice of bacon would lower your lifespan by 9 minutes. So this is, as a professor of mine once said, figures don't lie, but liars can figure. And you have to watch these statistics that are coming out of the lay press. Just as you have to watch the so-called studies and whether or not they're valid. One last question. I'm seeing a lot of increasing interest in sleep and the amount of sleep, and lack of sleep is listed as a risk factor for many diseases, including cardiovascular disease, Alzheimer's, etc. How about sleep and cancer? Is there any evidence that abnormal sleep patterns are linked to cancer or increased risk of cancer.
Yeah, there are lifestyle studies that show that night shift work is associated with higher cancer risk, and that has to do with disruptions in sleep cycle. Because if you're working night shift, I mean, you're working 4 days a week, and then what do you do the other 3 days? And so there's a lot of sleep disturbance, and it's typically associated with also higher levels of obesity and also inactivity. It's hard to separate those things out. There are studies that show that interrupted sleep or exposure to white or blue light at night also increases insulin resistance. So, again, insulin plays a role in that. It's an interesting subject in terms of those sleep studies and trying to tease these things out.
I think it's hard, to isolate that because it is so connected with also things like diet. There's studies on diet in night shift workers and weight loss or weight gain, what time you should eat your bigger meal during the day, and how your metabolism is affected by what you eat and what time you eat. So when you work night shift, that's altered. And I think, lack of sleep also speaks to your stress level and higher cortisol, and again, to the insulin resistance. So I think it's all, we're one system, we're one being, we can isolate one thing, one bacon, 9 minutes. I mean, how do you even do a randomized controlled trial on that? Somebody took some big study and then whittled it down to this factoid, ridiculous factoid. But, I think it's hard to isolate that in once because it affects you in so many other ways, your diet, your stress level, and then again, it affects your insulin resistance.
I think sometimes there's a confusion between length of sleep and quality of sleep. And recognizing that just because your eyes are closed, that doesn't mean that you're getting the full benefit from it, because the products of your sleep, the first 3 hours are all about restoration of your body, letting your body restore, regroup, heal, recover from the day's events. The next part of it is all about brain recovery and let it shut down. So if you're on your phone right up until the minute you go to sleep, you're going to completely destroy that. If you're watching TV, you're going to destroy that. So there's some very simple things that you can do that allow that to achieve what sleep is supposed to, which is restoration of allow a reset, a reboot of your body, if you will. And at the risk of sounding homey, my mom, I just say hot bath and good night's sleep, and then go to work. And I think there's a lot of truth in that.
After working 30 years as an emergency physician, I had to learn how to be able to not just sleep on demand, but be able to switch my sleep cycles. And one of the key things is you need to be in a cool, dark, quiet room without any interruptions. If you've got a clock that's illuminated, face it away from you. Your body does register those things. And it's getting back to what Dr. Fuller said. It's restorative sleep that you need. It's not just the quantity, it's the quality that's important. So there are no more questions in the chat box. So we're going to allow our panel to leave a little bit early. I really want to take this opportunity, though, to thank our illustrious panel. As I said before, I see their work product. It comes across my desk, their clinicals, the way they treat their patients, their diagnostic acumen. We didn't even get into the things like treatment, but how cutting edge the medicine that's being practiced here at TMMC. I'm proud to be a physician at TMMC, and I'm proud that we have physicians of this caliber. So let's give them a huge round of applause.